live.
Okay, let's go. Here we go, everybody.
Hey, everybody, so happy to see you here tonight. We are so pleased to have with us Amy Korn-Reavis, who is going to talk with us tonight about nighttime urination, why it happens, and what you can do about it. And we apologize and are sad to say that we will not be having Kevin tonight. He will not be with us, but Justine and I are filling in for him. And welcome, Amy, and thank you, Justine.
Thank you for joining us, Amy. I know that all of our community is excited to hear what you have to say on this hot topic.
Well, I appreciate you inviting me. I love talking to the people about sleep and whatever they want to know about it.
Well, I like the way that I like your approach with patients, and I try to not embarrass people, but I'm going to embarrass Amy right now. I've been watching her for years, and I just thought, wow, this lady loves patients. I could just tell, and the way that she presents to them is just wonderful. And so I say, hats off, and she's my hero. So I've always said that. I met her just not too long ago in person, and I told her that. So,
well, we're happy to have you here since you recently got your certification as a clinical sleep educator. So you are well versed to, speak to us and to our patient community about this Nocturia condition and what it is and its symptoms and why it happens to so many OSA patients.
So yeah, that's one of the big things that I hear a lot of patients ask. When I do sleep studies, the first thing they say is, I go to the bathroom all night. Is it going to be a problem? And I'm like, no, everybody says the same thing. The thing is that our bodies are designed for us not to go to the bathroom all night. This is not a part of our aging process. It's not normal for you to get up 2 and 3 and 4 times a night. So what happens is that when we go into REM, our body produces something called antidiuretic hormone. What it does is it keeps us from going to the bathroom all night. But when we have sleep apnea, your REM is the worst because that's where our muscles relax and our airway closes down the worst. Our brain understands that, I'm not going to breathe. I don't want to stop breathing. I don't want to drop my oxygen. So it's not going to want to go into REM. Plus the fact that right before REM and right at the end of REM is where we usually arouse naturally to change body positions. It's normal. Everybody does that. What happens with the sleep apnea patient is they'll arouse, and instead of just arousing and rolling over, they wake up and now they feel like they have to go to the bathroom because they didn't produce this antidiuretic hormone that keeps us from having to go to the bathroom. And so every time you go into REM, every 90 minutes, 120 minutes, you're going to feel like you have to go to the bathroom every 90 minutes to 120 minutes. But a lot of people have excuses to why they think they do this. I hear age a lot, and that's not a part of aging. Women complain about it a lot, and they're willing to talk about it more, but they think it has to do with the fact that they've given birth, and it doesn't. There are other problems with that.
Does it affect men more than women, or it doesn't?
No, it does not. It's just that women are more willing to talk about it than men. Men would never admit that they get up 3 or 4 times a night to go to the bathroom. That's just not cool. And I'm not trying to be sexist. It's just the way it is. Men don't talk much about their bodies as women do because we're kind of used to it. We have to because we have different things that happen during the years. So, but I still get, for my patients, my home sleep study patients, my CPAP patients, that they have this problem where they're getting up to go to the bathroom all night. The good thing is if we treat our sleep apnea, that will go away because we'll be able to go into REM. But it's not going to happen the first day you're on CPAP. I'm sorry to say, it takes time. Our body has chemistry and it likes to stay the same. So once we go on CPAP, our body chemistry has to change, and it does that slowly. It's kind of like losing weight. Nobody does it really fast. We've all had sleep apnea for a really long time. So our body takes a little time to adjust and change chemistry and go into REM and stay there. And so the problem will get better. I always tell my patients within the first 2 weeks of when you start your CPAP, that's where you start to see just memory changes. About 6 to 8 weeks is when you start to see more energy. This is also where you'll see that you're not getting up as often to go to the bathroom.
Okay. Are there any, I was just going to say, are there any other causes that someone should be aware of that they're getting up all throughout during the night that they should speak to their doctor about?
There are definitely reasons to be getting up. You will find that if you are on diuretics, I'm afraid that there's no fix for that. So if you're taking Lasix or something else for congestive heart failure or high blood pressure that causes you to have to go to the bathroom, and usually they take it at night so they don't have to go to the bathroom all day, well, that just means you're going to go to the bathroom all night. So your choices are kind of take it during the day and go to the bathroom, or take it at night and go to the bathroom. The other times that you may see it with men, if they have prostate problems, again, they tend to go to the bathroom a lot simply because of the way their bladders are now working. And that's a doctor thing. Or if you have a kidney infection or a bladder infection, that can affect it also. So you should never ignore if you're going to the bathroom a lot at night, because there are other issues that you could have.
Okay. So encourage people to speak to their physician about it, and you know, get under their care and direction to try to get it under control as best they can. Okay.
Absolutely.
Sounds like great advice to me. That's so important. I mean, that you know, I mean, none of us are doctors. Go to the doctor, for crying out loud. Don't be ashamed. It's a natural part.
You were saying that some of your nighttime awakenings to go to the bathroom can get minimized once you get acclimated to your CPAP treatment. Or speak to your doctor if you're on various types of medication that may be causing you to get up during the night. What are other strategies if maybe those two things don't seem, well, especially the CPAP therapy? Is there any other strategy that someone can utilize to maybe, you know, minimize their awakenings to have to go to the bathroom?
Yeah, actually, you could like train yourself. And I know this sounds kind of weird. They use it sometimes with people who have bedwetting problems. It's basically cognitive behavioral therapy type of technique, whereas you would set an alarm for a specific time and get up and go to the bathroom and then go back to bed. Your body will know that and get used to that, and then it will wake up at that specific time every night to go to the bathroom after some time. You know, if you think of your brain as a computer, and you ever watch a computer when it shuts down, it always goes through the same steps to shut down. Your brain likes to do the same thing when it sleeps. It goes through these cycles of sleep where you're in different stages of sleep. You start off at stage 1, which is that nice drifty, know what's going on. Then you go from that one, you're going to go to stage 2, which is where we spend a majority of the night. And then at the first half of the night is when we do most of our stage 3 sleep, which is that nice deep sleep where, you know, when you watch a baby and they sleep and they look so peaceful, that's stage 3 sleep. During that stage is where we produce things like growth hormone and where we consolidate our memories. And there's a lot of very important things that happen during that stage of sleep. And we come out of the slow wave sleep, and then we go into what's called REM. And REM is actually our lightest sleep. Most people think that's where we're deepest asleep, but it's actually where we're the lightest asleep. And we do that every 90 minutes to 120 minutes, approximately. Everybody's a little different. There's always going to be an exception to the rule. But if we're doing this every 90 minutes to 120 minutes, but if we train our brain to say, okay, I know at 2 o'clock in the morning, before I go into that 2 o'clock REM cycle, that I'm going to get up to go to the bathroom, and you do that repeatedly, your body will say, okay, I know that I'm just going to wake up that one time because I know that's when I need to go. So it's kind of training.
Mm-hmm.
Mm-hmm.
And that works well for children too. So if you have like a bedwetter, as well as restricting fluid before bed, you know, the 3 glasses of water that they want to drink before they go to bed because they're trying to delay going to bed, you need to avoid that. And the same is true with the adults. You cannot drink 16 ounces of water and then go to bed and not expect to have to go to the bathroom.
Yeah, really.
Try to give yourself a couple of hours, let your kidneys work a little bit before you go to bed.
Very, very good advice. I know. I remember those times where I have to have a drink of water. I have to have,
Yep.
you know.
Well, it's interesting that you mentioned the pediatric aspect of it. My daughter is soon to be 11, and she was diagnosed with pediatric apnea. We have been, she's been using a CPAP machine since she was 4. She wears a nasal mask. And we've also been, you know, doing various types of orthodontic work, you know, rapid expander and a few other things to just make sure her palate and mouth don't collapse, as is in our family, hereditary, I guess, hereditary to our family. But it was interesting that one of the things that her sleep physician at Stanford University told me, because obviously parents deal a lot with bedwetting with children, it's, you know, relatively common. You know, one of the things that really surprised me, because you read all these new parenting books about what to expect and how things happen. And, you know, he kind of brought it to the forefront of my mind that, you know, while periodic things or occurrences may happen, something that's really, really chronic with a child, you know, might be a sleep disturbance that they're having. I mean, obviously, if, you know, the one time they drink the 5 glasses of water before bed and then have the accident, that's probably, you know, the cause for that particular situation. But then, you know, if it's something that's happening over and over again, to talk to your pediatrician about, you know, maybe their sleep and what's happening. Because just as you described before, all of those hormones and chemicals and everything, as you're arousing and going back and this and that, get released. The same thing happens in children, and then you have to go to the bathroom. And you know, because they're 4 or 7 or something, they might not make it to the bathroom in time.
And they might not understand what they're experiencing either. I think that the big thing with children and sleep disorders is that we don't recognize them because we, as adults, we think it's all about the snoring, it's all about the weight. And with pediatrics, most of the time, they don't snore. They tend to toss and turn a lot. They don't necessarily snore very loud. But the other thing that you find is that children who are sleep deprived, because remember, sleep apnea is going to make you sleep deprived because you're not getting that good night's sleep, is that they get hyperactive when they're, rather than sleepy when they're having, when they're sleep deprived. So the kid who's bouncing off the walls every day could just as easily have a sleep disorder as he could be hyperactive. So you should always talk to the doctor. One of the best things you can do is maybe keep a 2-week sleep diary and say, this is when they went to bed, this is when they woke up. Because if this child is chronically sleep deprived, maybe there's things that you can do to fix that rather than start them on medication as the first line of treatment.
Right, right. That's a very good point. That's a hot topic these days. I see one question coming here on Facebook, since we're talking about pediatrics, from Michael. He was curious, and you know, maybe you can guide him a little bit with this question. Was curious to hear for pediatrics, is there a particular stage where they're more likely to wet the bed? Is it in the 1, 2, 3 that you were talking about before?
So with children with parasomnias, most parasomnias, that's sleep talking, sleepwalking, anything like that, is going to happen during stage 3 sleep, which is your slow wave sleep. And remember, children are growing, so they spend more time in slow wave sleep. As far as bedwetting is concerned, it depends on why they're bedwetting. Sometimes it's because they're in stage 3 sleep and they're so deeply asleep that they don't feel it and they don't wake up. Or they could be doing it in REM because they're having sleep apnea problems. So it's all a matter of, that's why they have to be followed by the doctor, and they really need to be seeing a doctor who knows what they're talking about when you're talking about sleep.
Right. So maybe it's good advice if, as a parent, if you're maybe struggling with some bedwetting for your child or your children, to, I think we mentioned before, keep a little bit of a sleep log, and then go ahead and talk to your pediatrician or maybe a specialist that, you know, is in your area on your health plan, to seek out some, you know, different answers or options.
Absolutely. But if you come in with the sleep diary, at least you're prepared. I think that we go into the doctor and we give them something that's not very concrete, something that's kind of broad, like, oh, he's bedwetting. But you don't tell him how many times it's been, or what time of night you notice it. These things actually make a difference, because the time of night kind of tells you what stage of sleep they're going to be in. That's why these sleep diaries are so important.
What time they went to bed, if they had the 5 glasses or no water for, you know, hours before, and like you said, what time the incident may have occurred, and if there's anything else maybe throughout the day that was different or extraordinary that happened, or, you know, just to note those things down. I think that's good advice. They always say that when you go to the doctor, you're supposed to go in there with your little sheet of, you know, the questions that you have and what you want to talk about, because you get in there and, you know, it is a little bit of a pressure cooker on time sometimes, and you get nervous or just trying to move too fast and you gloss over things, you forget. You know, I mean, I've done that myself. I leave the doctor's office and say, I can't believe I didn't ask them that. It was one of my questions that I had and I didn't ask it.
I always had lists when I took my kids, and that was a while ago. My children are all grown now. But that was one of the things they did, was I would go in with a list and I would say, well, we're doing this, we're having this problem now, or we're having that. Or I was following up with one of my kids because I had a child who also had some needs, unusual needs. So when we went to the doctors, we had to be very specific about what was going on. So those diaries really matter.
Yeah, that's good advice. We have another question here. We talked about having nocturia, you know, related to sleep apnea. But how would you recommend that individuals manage that? Because from the perspective of, I'm sleeping, I have my machine on, I have my mask on, and now I do wake up and I go to the bathroom. And so, you know, that might send people into the annoyed category, because they have to take off the mask and they have to go in and they come back, and now it's this whole thing. And then maybe sometimes they even think to themselves, I'm not putting it back on. It's 1 o'clock in the morning. I slept with it for 4 hours, I'm done, or 3 hours, I'm done.
So here's the thing. I'm really fussy about what masks. When I fit a patient for a mask, because I do fit patients for masks, some of my patients, I'm very careful about which mask I choose. Some of the masks are set up so all you have to do is disconnect a hose at the mask and you don't have to deal with the headgear. So with somebody who's struggling with that, a change of mask might be a better option, because you want a mask that's easy for you to deal with. We don't want to be necessarily dealing with a headgear issue at 2 o'clock in the morning. I was dealing with a patient who was having problems because he did get up at 1 o'clock in the morning, and he's like, well, I went to sleep just fine, but at 1 o'clock, I can't go back to sleep. And I said, okay, so let's talk a little bit about this. Well, he used the ramp to go to sleep every night. And for those of you who don't know, the ramp chops the pressure down, and then it slowly builds up over a period of time to the pressure that the doctor ordered. We usually set it about between 20 and 40 minutes, depending on pressures and how sensitive people are. So he was using the ramp at the beginning of the night when he went to bed, but when he came back to bed, he didn't hit the ramp. So he's going back on with the pressure full on, and then he's wondering why he can't fall asleep. Well, you didn't fall asleep with the pressure full on at the beginning of the night. You need to do the same thing when you get up at 1 o'clock. So remember, if you're using a ramp on your machine or a ramp button, there's no rule that says how many times you can push it. And
that's right.
It's all about comfort. The doctor is not sleeping there with you. Well, unless you're married to the doctor. They're not going to be sitting there sleeping there with you. They don't know what you're going through. I'm always very careful with my patients to teach them different ways to desensitize themselves to the mask.
Absolutely.
And deal with problems as the night goes on. There are people out there. Sometimes it's from the durable medical equipment company. Sometimes it's the doctor. Sometimes it's the sleep clinic. So you have to know who's going to be your support or clinical support for you and where you're going to get that from when you get your CPAP. Do you know, my patients know for my sleep lab, I'm in a very small sleep lab. We're an independent testing center. There's one building, it's 3 beds. The patients leave, the doctors and the patients all know that they can come to me, and I can look and I can say, okay, this is what I see. Maybe you need to do this, or maybe you need to do that, or I'll call the doctor and I'll say, listen, this is what I'm seeing. The machine's broken, we need to get it fixed, or the patient's getting up and they're not tolerating this pressure right now. Can we drop the pressure for a little bit and then build it back up? There's always somebody in your network of people who are working with you in sleep that can do what I'm doing for my patients.
Right. One of the questions we had on Facebook from Susan, and you touched a little bit on it, was, she says here, I'm having such a hard time getting used to my full face mask, which is kind of what you were talking about, the desensitizing. And I mean, do you have maybe just some maybe not common tricks of the trade that you have given people?
This is my take on the full face mask. One, I hate full face masks unless they absolutely are needed. But if you're getting used to the full face mask, do not go to bed with it in the beginning. Put the machine in the living room. Put the face mask on, or if you're a little bit claustrophobic, hold the face mask to your face. Watch TV. Not something that's going to stress you. No news, no sports, because sports will piss you off. You want something that is entertaining, and you're going to wear it for 20 minutes. We can all do anything for 20 minutes. If you can't wear it with the headgear, then hold it to your face. Make sure it's got a tight seal, though, for 20 minutes. The next day, go 25 minutes, then 30 minutes, then 35 minutes. When you get to being able to wear it for 2 hours comfortably, then move it back to your bedroom. I've been doing this so long that I know that 2 hour mark, if you can wear it for 2 hours during awake time, then you can sleep with it. But if you go and you put it on and you're having a really hard time getting used to it, it's because you're sitting there, it's quiet, it's dark, and you're staring at the ceiling, and you're getting into your head and you're stressing. And you're thinking about, how should I breathe? This mask feels funny. What happens if I turn over? We just get into all these thoughts, and it's so hard to get past them. So you take it out of that environment. Does that make sense?
Yeah, I mean that I like the idea that it's something positive about if you can get to that 2 hour mark. I have heard before, watch some TV with it, do something a little more relaxing, than trying to sleep. I assume you can lie on your couch and read a book for 20 minutes if that's what you want to do.
I think reading, though, there's the problem with reading is, one, if she's on a full face mask, the mask can kind of get in the way of reading.
Right.
The other thing is reading is a very quiet activity and requires some concentration, and that the CPAP can it's kind of like staring at the ceiling.
Okay.
So I don't necessarily recommend reading as the choice activity. It needs to be something a little more visual. Put a movie on. Just don't just sit there, okay? Because that's just as bad as sleeping there. You need to have something that gets your mind off of it.
Yeah. But that's good to hear about the 2-hour thing, that, you know, for someone that's trying to work through their issues, you know, that they can, you know, have a little bit of a positive reinforcement, that if they can watch 2 hours of a movie and be relaxed and everything's fine with their mask, then they're going to have a pretty good chance of being very successful then when they move it to actually go to sleep at night. So that's good.
Well, here's the other thing with that, so that way people understand this, because you'll get these phone calls from the durable medical equipment company. You have 90 days to get 30 days of compliance. Compliance is, I'm going to wear that you have to wear your mask for 4 hours a day for 30 days. Okay? A minimum of 4 hours a day. And 3 hours and 59 minutes does not count. So the DME companies will say, oh, I see you're only wearing it 30 minutes a day or 35 minutes a day in the beginning, and they're going to try to push you to wear it longer. I have 90 days to get somebody compliant for 30 days. If it takes me 2 weeks or 3 weeks or 4 weeks to get a person into bed with it, I still have 2 months to get them compliant. So don't feel like, oh, I got the CPAP and now I have to get it. I have to get to sleep with it now. You have a little bit of time, and they're not going to take your machine away from you next week if you've just got it.
Right. That's good advice. That's good advice. And I think, you need to talk to them about the plan that you're on and the tactics that you're trying, so that they know as well that you're not just, lying in bed with it for 20 minutes and taking it off because you got frustrated, that you're trying to, use this type of behavior or behavior therapy or something of that nature.
Absolutely.
So. I have another question here from Jim, talking about his bed partner, his wife, saying that the mask is just too noisy. And so he's looking for a non-noisy mask, which I kind of think leads me to believe that it's probably not fitting properly, whatever he's trying to use. Because I use a CPAP mask, my husband does, my daughter does, and they're relatively quiet. I guess maybe not if you have a nasal mask and you open your mouth too much, you might get a little bit of a noise.
Well, there's other issues. Facial hair causes leaks as well. There are a couple of products that are liners for masks that sometimes help with, if you're having problems with the seal. There's Patacheek, which makes cotton cloth covers for the mask. And there's Remzi, which is a liner that's disposable that will also help with the seal of the mask. I don't know if he's got a full face mask or a nasal mask, and he's not my patient. But if you're having this problem, the first thing you should do is go to the durable medical equipment company where you got the machine and tell them that the mask is not working for you. During the first 30 days, the insurance will pay for you to change the mask. After the 30 days are up, then you've got to pay for it out of your own pocket till you've had the mask for 6 months.
Okay. Well, Teresa, any questions over there on the other group that you see? I might have lost Teresa there. No problem. So are there any other helpful tips that you give to your new patients? They're starting out on their CPAP machine. We talked about, being in the relaxing setting, using it for a regulated amount of time to get used to it. Anything else? Because I mean, that's probably one of the biggest questions that in your field and that we get when someone is newly diagnosed. How am I going to get used to this? How am I going to wear this thing to sleep? So
I do a couple of things. It depends on the patient, because I really have to get to know the person to see what might work for them and what might not work for them. I do some progressive relaxation exercises for like my really tense patients, because progressive relaxation will help you to relax your whole body. And so you're not stressing on it. I also am very careful to tell patients, don't worry about how you're breathing. I don't care if you breathe through your mouth. I don't care if you breathe through your nose. I don't care if you're standing on your head. What I care about is that you're able to sleep. Your body will do what it needs to do once you're asleep. I don't like chin straps, because I think, again, all that's going to do is it's going to make your lips go, and who wants to listen to that all night? Your bed partner's going to complain just as badly about you sounding like a duck or a motor. So I don't use chin straps for most of my patients. A very rare occasion I will, but I don't think that they're the be all and end all. I think you need to not worry about, should I breathe through my nose or my mouth? I think you need to worry more about just wearing it and becoming comfortable with it. And I think you need to learn to relax. I think the other big thing is we go over that you need a bedtime routine. Everybody needs a bedtime routine. Going back to the computer, when we turn off our computers, it goes through certain steps and then it turns off. Our brains are the same way. It needs that same cues to say, okay, it's time to go to bed. We do that for our children. We have them change their pajamas, they brush their teeth, we give them that glass of water, we read them a story, we tuck them in, and we go to bed. That teaches them that, okay, this is bedtime, we're going to do this. This gets their brain ready for sleep. We do not do that for ourselves. We're adults. We also have really bad sleep hygiene. And so we don't worry about what temperature the room is. We don't worry about how dark it is. And the bane of my existence is the electronic stuff that's on before bed, because we're not producing melatonin. Melatonin's produced by being exposed to dark, not a reduction of light. It's by being exposed to dark. So if you're not exposed to dark, you're not going to produce melatonin. That's not going to let your brain go to sleep. So if you're sleeping in bed with your cell phone, your tablet, or whatever, those blue light filters really aren't helping you any, because you're just not going to produce the melatonin you need.
yeah.
It's very good advice. You see it every day. Someone says, put those things away. It's so bad, for sufferers of, being able to get to sleep and be able to relax with the machine. I mean, I always used to tell my patients, make sure that you get a visual. Try to relax, especially some of the more nervous people. Try to relax. Let that pressure fill the back of your airway, sort of like you have an invisible balloon in there, holding it open. And if you can get that visual sometimes and you meditate, you can get down into a place where you need to be, where you'll just drift off. So relaxation
that's
is
why I
so
use progressive relaxation. I think that because I can't sit and meditate. I'm sorry. I'm a little bit too type A to sit quietly and meditate. I just can't do that long. But I can do progressive relaxation, because that lets me have movement and concentrate and count, so I can relax.
Amy, tell them how to practice that. It's a very interesting, if you haven't heard of progressive relaxation.
I always start at the feet. Some people start at the top of the head. I start at my feet, and you're going to tighten the muscles in your feet, and you're going to hold it for a count that you're comfortable with. I like the number 8 because it's not, it's not 10. It's not a low number. 8 is a really good number for me. So I tighten my muscles as tight as I can in my feet. I hold it for the count of 8, and then I let it relax. And I let it relax for 8. And then I do it a second time, and I tighten as tight as I can, and then I relax. And then you move to your calves, and then you move to your thighs, and then you move to your bottom, and then your belly, and your shoulders, and your arms, and your hands. And the last thing I always do is the face, because but by the time you get to the face, the rest of your body is so relaxed, it just gives you that, it reduces your blood pressure. It just gives you that moment of, but it gives you something to do because you're counting to 8 all the time, and you're breathing when you're tightening the muscles, and you're breathing nice, slow, deep breaths when you're relaxing. So it's a lot of, gives you a lot to focus on. Whereas meditation, you're supposed to be trying to empty your mind of thought. I can't, no. So this gives me something I can think about.
Yeah, well, I think.
Go ahead, Justine.
I was just going to say those are 2 good options for for people. We have another question here. Let me see. I lost it. Oh, here it is. This individual wanted to know, why do some people still suffer and feel fatigue after they're starting their CPAP therapy? They thought that maybe that was going to reboost their energy and kind of, now that they're getting all of the quality sleep that they weren't receiving before, give them a little pep.
So with some people, they're finding that even though we give them the sleep and it does improve their health, it doesn't necessarily improve their energy because there are other things going on. They've done a whole lot of research. There are a couple of new medications that are supposed to be coming out in the next 3 to 6 months that are specifically designed for CPAP wearers to help them with that energy issue. Remember, this can also be hiding other things that you have. Once you treat the sleep apnea, it doesn't mean that you don't have any other sleep disorder. It also doesn't mean that there aren't other health issues. Like I'm going to use me for an example. I tend to be anemic. I'm always very anemic. So that means I'm always going to be tired because I don't have enough oxygen going to my body because I don't have enough red blood cells. That's just, or enough iron in my red blood cells. Treating sleep apnea is not going to fix the anemia. So treating your sleep apnea is not necessarily going to fix what's making you tired, but it is eliminating other potential health problems that you could either have now or could have in the future. I always think of CPAP as preventative health care more so than treatment health care. Because when we take something for a treatment, we're taking it to cure something that in the short term, like an antibiotic or something, where this is preventative care. We're going to keep our airways open. We're going to keep our blood pressure down. We're going to get good sleep. We're going to reduce our chance of diabetes, reduce our chance of colon cancer, reduce our chance of Alzheimer's, reduce our chance of macular degeneration, because all of these things are associated with sleep apnea.
Yep.
So I didn't give her a good answer about the fatigue because there's not necessarily a good answer, because I don't know what's wrong with the person, and the person, if they're continuing to have fatigue, needs to follow up with their doctor to make sure that there's not something else going on that was covered up by the sleep apnea.
Right. And I agree with that. I think that, you're focusing on your sleep, getting good quality sleep, whether it occurs naturally for you or you need assistance with a CPAP machine, it sets you up for let's say hopefully a healthier lifestyle. But we all have various, hereditary issues that we've had from our family, whether it's high blood pressure or cardiovascular and this, that, and if you're treating your sleep apnea, hopefully those things aren't as compounded as they might be if you weren't treating it. But you might, and it's not a 100% magic pill. That would be great if it was, but it's not. So you still have to keep in mind all of these other things and how you're feeling and your symptoms, to make sure about that. It is helpful when your physician, finds your apnea diagnosis, because sometimes it does take all of those other things that you're feeling down some notches, so you can actually focus on them and try to seek out some other advice and care.
Yeah.
Yeah.
Amy, you were talking a little bit earlier about a sleep diary or a sleep sheet or whatever. Do you happen to have one that you give out to patients? And the reason I'm asking is because if someone wanted that and we connected them with, if they want to contact us, we could help them, get to you for that, because or maybe you want to sometime just post one on our Facebook group, but or we can email it to someone.
I have one. I do keep one. I do have one. I have one for the sleep lab. I have one for my website as well.
Okay.
So they can.
That would be great to share with everybody, because it is very important. Not only for the urination issue, but sometimes we have foods that we might have within 2 hours of bedtime that can disturb things, and the gastro issues and that kind of thing. I mean, it's always good to track what you've done, what worked, what didn't work. And I would just be so grateful if you could share that document that you have with us, with our readers, with our guests.
I'll go ahead and upload it onto the Facebook page. So
thank you. Thank you.
People are more than welcome to go to my bettersleepcoach.com website. I have lots of stuff up there for them.
Yay.
I have lots of blogs, and that's a great way to get contact with me. There's a contact sheet in there. So if you want to contact me, you're more than welcome to. Because I like to take care of my patients. I like taking care of people, and I'm always talking about sleep. I'm such a sleep geek.
I know, honey, but it's all right. We like sleep geeks.
But to give you an idea, I have the world's weirdest allergy, and I'm going to bring it up because this is the time of year where my allergy actually matters. I am allergic to nutmeg. I know that's a weird allergy, but the only way we were able to figure out how that was what I was allergic to was by my keeping a diary of saying, this is what I had, and this is what I had, and this is what I had. And so we're like, oh, wait a minute. And why do I get it more often during the fall? Because everything is pumpkin pie spice.
I was going to say, it's pumpkin spice latte time. That's why you have.
I can't have any pumpkin spice anything because it's all got nutmeg in it, and I'm allergic. And the last time I spent a day being IV'd with Solumentrol, and I'm not going to do that again.
Well, Amy, I am just so happy that you could join us tonight. I'm very proud to have you here and talking to our wonderful patients and friends of the American Sleep Apnea Association. I hope that you'll come back again sometime with us.
Anytime you need me, you know where I am, Teresa.
Oh, thank you, dear.
Thank you tonight, Amy, for giving all of our patients some great information.
Oh, my pleasure.
Good night, everybody. Thank you.
Good night. Thank you. Bye-bye.